I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Hello, Jam. Nice to see you again. We may have left some of you dangling. Huge apologies. But Jam, what have you been up to?
Yeah, thanks, Al. Great to see you on a lovely balmy Sunday evening. We've been releasing one pod a week for the first 13 episodes, I think.
Yep.
I think we have decided just to go a little bit slower over the next few months and do one every other week so we can really engage with all the feedback that we're getting from each episode to make sure that actually each subject can be covered in more detail. So we're going to have podcasts and little videos and other layers of information that will be sort of built across all our platforms, which I hope will just enrich the experience that we've had so far.
Yeah, looking forward to moving on with all these additional kind of projects. But of course, and we always say this, but we really, really do mean it. Let us know what you think. If you prefer weekly or, I don't know, any other way of getting your content or hearing from us, then please reach out and let us know, because we're just going on gut instincts here and you guys know best who are listening in. Tell me what's happened in your world.
The year is going quickly. We are, nearly in the summer holidays now for the kids. It's been a busy time. We've got new treatments that we talked about last week. So we're embedding that new protocol. People are starting on that. So we're starting to get feedback about belantamab and that kind of thing.
Yeah, in Bristol and Bath. I mean, it's continuing to get an awful lot of traction, actually. Those headlines, they really grabbed everyone's attention, which is a fantastic opportunity. And actually, that coming so close to Myeloma Awareness Week, I think was a gift, really, wasn't it, for our patients, that they can communicate with other people who perhaps don't understand myeloma so well about these developments, which are extraordinary. So, yeah, we've been busy trying to get our ducks in order or in a line or whatever the expression is to really get cracking this new regimen. And apart from that, ticking over.
Brilliant. I've had a number of ophthalmologists invite me for Chinese food. Now, if you haven't listened to the last podcast, that probably makes absolutely no sense. But I've had all sorts of delicious Chinese meals, courtesy of my ophthalmology colleagues. So thank you all very much.
I imagine you shamed yourself, Jam, with your messy chopstick technique.
Well, I tell you what, I did.
So, Jam, today we're going to pick up kind of where we were a few pods ago when we were talking about what happens to people when they're just starting their treatment for myeloma. And just to remind our listeners, we spent a few pods talking about those patients who may be having treatment for a transplant and those who won't be having a transplant. But today we're going to focus on the former group of people, so those going forward for a transplant, and what comes next after you've had your initial treatment and your myeloma is hopefully nicely controlled. What happens in that period before your transplant? How do we prepare people for their transplant? And we're going to focus this podcast on what we call stem cell mobilisation.
So I think it's very important to understand what stem cells are, and understanding what they are helps then explain what a stem cell transplant is. So there's lots of different types of stem cells. Now, we're specifically talking about bone marrow stem cells. And these are very clever cells in our bone marrow that have the ability to turn into all the different types of blood cells that develop and mature in our bone marrow before they're released to do all the jobs that they need to do. Without these bone marrow stem cells, you wouldn't be able to live, because your body would fail, because you wouldn't be able to make enough red blood cells, platelets, cells to fight infection. One of the key things about any chemotherapy is that a lot of the time, the dose of any chemotherapy, now this is for many different tumor types, is limited by a number of things like toxicities, like how sick it makes people or serious infections people get, but also how toxic it is to the bone marrow. So if you kill your bone marrow stem cells with chemotherapy, then you're in trouble and you're going to have a hard time surviving. So over the years, people have understood that these amazing stem cells in the bone marrow can be harnessed, mobilized, and collected. And what that then does is then that gives you the ability to potentially give stronger treatment, knowing that you're going to actually kill the bone marrow stem cells. So you have these stem cells that then you've got in reserve, as it were, to allow you to then replenish the ones that you've killed with chemotherapy. Of course, well, people say stem cells, how do you move them? Like they're in the bone marrow, and questions people have, it's like, well, How do you take them out? I'm not having 30 bone marrow biopsies for you to collect lots of cells. How do you store them? What is the process?
Beautifully explained. I mean, good effort. I think these are complex ideas to kind of get across, really, isn't it? I mean, I describe stem cells as parent cells. They're sort of like the parent cells that then make the children, which go out into the world and do what they need to do, like ours somewhat, let's hope in the future. They will eventually leave home. But yeah, so these parent cells, these stem cells, we need to collect them from the body. And they do live, they reside within the bone marrow. But there are special drugs that you can give which sort of boost their growth within the bone marrow, or make them sort of wake them up, so to speak. And so they sort of can spill over into the blood, into the circulation. And from there, you can siphon them off using very clever techniques, collect them literally in a bag and freeze them down. So I think once you get your head around it, it's quite easy to understand. You just really want to target these parent cells and store them so that later you can use them. It's really important to say that process of taking the cells, whatever they are, out of the body to use later is why we talk about a transplant. This is not the type of transplant where you're giving someone a kidney from somebody else or a liver from somebody else, but it's more that the cells were in the body, they've left their body, and then they go back in to the same body, the same person, and that's a transplant process. So what we call harvest these cells, which I always again think is a really weird expression, but I suppose it makes sense, doesn't it? You're harvesting the seeds, which are then going to enable the rest of your bone marrow to recover and grow. The process by which we do it varies from centre to centre. I know where you work in Oxford, you use particular drugs to calm the bone marrow down before you then try and waken up to collect the stem cells. Where in other centres they go without those drugs.
So I highlight a couple of really important points you made there, Sally. It's fantastic that you can do this process without actually digging into the bone marrow, because a couple of decades ago, that's how you did do it. The only way you could get the stem cells was actually putting people under general anesthetics and actually physically doing multiple bone marrow biopsies on each side on the same patient. All of you listening that have had bone marrow biopsies, I mean, can you imagine? It's not much fun. We've both been in hospital, Sally, where we've had to pretend to be surgeons and gown up and collect all those stem cells.
We have.
Yeah. It's very clear to me why I didn't become a surgeon going through all that kind of surgical faff. But it's amazing because, as you say, you can now use drugs, and this has been the process for many years, where actually, by using certain drugs, the stem cells will get into the blood after a certain number of days. And then you use a process using a special type of machine, which is a bit like a dialysis machine, but it's a special machine that can filter the blood and preferentially filter off the stem cells before they're stored and frozen. So you mentioned the drugs. So there's three main drugs that we should talk about in this process. There is a drug called GCSF, colony stimulating factor, which is a crucial and the crucial drug in the process. And there's two other drugs. One is a chemotherapy drug called cyclophosphamide, and the third is a drug called plerixafor. Now, GCSF is universal to stem cell collection. Depending on the protocol and the location, the other two drugs may be used.
It can be a little bit confusing to know why you're needing this drug or not this drug, particularly actually for those of you who communicate and are in touch with other people who've been through a transplant before. And it might seem like what you're being exposed to is a little bit different, but I think it's safe to say there is variability centre by centre. The key thing to remember is actually this is all about getting those stem cells by whichever means, and you have to hit a certain threshold of stem cells. You have to collect a minimum number of these cells for your transplant to then go ahead. And so sometimes you might need those additional drugs you've spoken about, the cyclophosphamide or the plerixafor, to make sure that your body makes enough stem cells for them to be collected to allow your transplant to go ahead. So it can be quite personalised, this approach.
So let's start with GCSF, Sally. So people may be very familiar with this drug as one of the commonest drugs used when delivering chemotherapy when people get neutropenic, which means their neutrophil count goes down, and this increases the risk of infection. In the context of stem cell collection, what is GCSF for?
Yeah, so GCSF, the clue is in the name, another acronym. Shout out there to those acronyms. So it stands for, if you were to break it down, and you've already referred to this, Jam, granulocyte, which is a fancy way of talking about a white cell, stimulating colony factor. And what it means if you're going through through this is you have to have an injection under your skin every day of this treatment called GCSF, and that then enables your bone marrow to stimulate these stem cells and to grow them in a relatively short period of time, so that, as we said, they can then be collected from the circulation from the blood later. And so you have these treatments under the skin at a certain time point. Depending on when your stem cells are going to be collected, you're advised to start the GCSF and then continue with it. And we can pretty much pinpoint when your body is going to have kicked in and made enough stem cells. And then we advise people to go into hospital, just a day visit, and to get a sample of blood to see if there are enough stem cells in that blood. And if there are, we hook them up to the machine that you've referred to, which is literally, hook them up, what an expression. It's not literally hook them up. It's rather terrible, the terms we use, isn't it, Jem? It's rather you put a cannula into their arms and you take some blood off. And then, as you said, you siphon off the stem cells and then you return the rest of the blood to the body. So that's sort of what GCSF does. It's before you collect your stem cells to make sure your body makes enough.
And for some people, they may just need 5 days of GCSF and that will be enough. And as you say, the cells you can measure. Before people go on the machine, you can measure to know that it makes sense to put people on the machine because there's plenty of those cells circulating, and then you can collect the desired number. Okay, so that is the GCSF. Now, in some places, and I have to say we're moving away from this now, I have to say, people use a drug called cyclophosphamide, a chemotherapy drug, which is given on the first day of the stem cell mobilisation process. This is a chemotherapy that's given intravenously. It's a drug used in a number of myeloma combinations as well, but is an older drug now, and we're using it much, much less than we used to. And this drug, given at certain doses, also starts the process of stimulating those stem cells to spill over into the blood. So you give that drug, and then for a number of days, normally 9 to 10 days, you give the GCSF, and then the same process happens and you go on the machine. I think there will be people listening to this who had a cyclophosphamide harvest. It's a drug which is quite an old chemotherapy, and because it's an old drug, it has some of those older side effects of some chemotherapies like nausea and vomiting and hair thinning. And it can be quite unpleasant.
So the important thing to say about cyclophosphamide is it's definitely had its place, certainly in the history of stem cell transplants. Prior to the advent of the newer drugs, which I'll speak to in a minute, it wasn't necessarily a given that you get enough stem cells from somebody. And now, actually, given that we're using more drugs prior to the transplant, it's less likely you'll collect a really high number of stem cells. Most people will collect enough, but with this combination of drugs, some people get just below the threshold. But what we can do now, which is different from before, is for those borderline patients where we can't collect the number of stem cells that we want, we can give them the third drug, plerixafor. So when we didn't have access to plerixafor, cyclophosphamide was incredibly important because that just topped up that stem cell collection number. It meant if you had that and the GCSF, the numbers you collect are likely to be higher. But now we can just give GCSF, and if your numbers aren't there, you get plerixafor the day of the collection and perhaps even the day after, and that bumps up your numbers instead. So you can almost do away with the cyclophosphamide in preference for this other drug, plerixafor, which is given similarly to GCSF. It's an injection under the skin, and it works, and doesn't work in exactly the same way, but essentially what it does is equally mobilise your stem cells, but it works more immediately and just bumps the numbers up a bit.
And what are the side effects of plerixafor, Sally?
Goodness, I don't know if there are any, aside from those related to sort of like GCSF. I mean, it's really important to say with GCSF, you can get significant bone pain.
Yeah.
And it can, it's almost like those stem cells are growing inside your bones, like growing pains. And as they do so, it can really, really hurt. But the most important thing to say is, even if you're getting that pain, liaise with your team. Don't stop the injections, because if you stop the injections, the whole process fails. And I imagine, I haven't seen that many side effects of plerixafor, but it's probably the same side effect profile, to be honest with you. But fill me in, Jam. Have you noticed other side effects?
I think it's very well tolerated. Some people can get a little bit of nausea, a bit of abdominal pain. But I think highlighting the pain with GCSF, Sally, is a crucial point. It can be excruciating, unfortunately, and painkillers, and strong painkillers often have to be used for a few days because the injections must be continued.
Yeah.
It is an absolutely crucial point. You very nicely highlight why we use less cyclophosphamide. I would say an additional reason is that cyclophosphamide in itself has anti-myeloma activity, and it will treat the myeloma. And now with modern 4-drug combinations being so good, we don't often need that extra burst of chemo as an extra kick to try and get the myeloma down before the transplant. So certainly stem cell collection is becoming kinder and a bit easier, actually.
Yeah, I agree. And near enough everyone does collect stem cells, don't they now, particularly with GCSF and plerixafor. And for those who struggle, sometimes, and this is really, a real minority of patients, you might need to go through the process again to try and bump up your numbers. But I think it's quite rare. I can't remember the last time somebody absolutely failed. I don't know if you've had anyone recently, Jam. I mean, it does happen, but it's very unlikely.
It's very unusual. And I mean, Sally, how long does the process take? So we talk about these machines that people are on. Does it take 2 hours, 4 hours, longer? We tend to get most people done in a day now.
I think it very much depends on what your stem cell count is in your circulation when your blood test is done. So if your count is a little bit low, you might be on the machine for a little bit longer to top up your numbers. Most people, as you say, are done and dusted within a day. So they come in the morning. They have this line put in, the cells are taken from their bloods, the blood is returned to their body, and they go home. But on occasions where we don't quite collect enough stem cells on that first day, they then come back the next day and go on the machine again. And it's that night that they then tend to get the plerixafor, which bumps up their numbers. And generally by the end of the second day, very rarely third day, but by the end of the second day, you're over the line.
Yeah, no, absolutely. And you mentioned that you need cannulas, you need good venous access. So if you think about it, all your blood volume is going through a machine and then being returned to you. So if you have good veins, this is a very medical term, good veins. Oh, you have good veins.
You can spot the good veins a mile off, can't you? Out for a night in the pub and there you are.
It takes you back to that first year of being a doctor where you're placing a lot of cannulas. It's like, I can only cope with patients with good veins. It's like somehow it's like their fault if you can't get in the cannula. But essentially, you do need to have big and prominent veins so blood volume can move quickly and the process can be completed. For people, unfortunately, who don't have that level of vein that's big enough, sometimes we have to use a bigger type of what we call line, which either goes in the groin or neck, but normally in the groin, where it goes into the big vein, the femoral vein in the top of the thigh, which means that you can get adequate flows of blood.
Yeah, absolutely. I mean, because these resources, I'm sure it's the same near enough all over the world actually, are finite. These machines are very specialist. So your slot is booked for you. So the last thing somebody wants is to turn up on the day and for whatever reason, for the machine to not be able to work properly because the blood doesn't flow as smoothly as it ought to. So making sure that sort of vein problem is dealt with in advance, so you've got what we call access, which means that blood can flow freely through the machine, is really important because you don't want to waste your slot. It's precious time.
Yeah. And what are the side effects of being on the machine? Will people generally feel a bit bored and be sort of sipping cups of tea and doing Sudoku, or are there side effects that can make it a bit uncomfortable?
Yeah, I mean, there are side effects, not least actually if you have got one of these larger sort of cannulas or access to your groin or your neck. Clearly that's not very comfortable. I mean, you cope with it, but you'd much rather that wasn't there. But also, as that blood flows out of your body and is collected and returned to the body, it can cause subtle changes particularly in the calcium levels of the blood actually. And so some people find that their calcium levels might fall. Now doesn't tend to be to a dangerous level because calcium is important. It does have to be in a certain amount of it within the circulation, but it can cause the sensation because it's quite a rapid change in those levels in your body. So your body notices it. And one of the ways your body notices it can be sort of like tingling around the lips. I'm sort of feeling a little bit just a bit tingly and a little bit off. I guess if you're not very well hydrated and all this fluid is being shifted around, you could feel a little bit dizzy or lightheaded, but I can't really remember the last time that happened. They tend to be the two main problems. But Jam, anything else that you've experienced?
No, I think they're the main ones. Low calcium, often people start to feel it, and the specialist nurses that look after this process, they're very good at measuring the process and replacing the calcium.
Yeah, it's easily dealt with, is it? It's easily remedied. It's just something to look out for.
And how many cells do we collect? So I think one question people ask, they're worried that if you take my stem cells, do I not need them? And we only take a fraction. I think that's the first thing to say. There are thresholds that we aim for. Generally, these cells are frozen, but they can technically be used fresh as well. But in certainly most places, they are frozen and then used later in due course as needed. How many do we collect?
Yeah.
How many are we aiming for?
Again, this has changed over time, hasn't it? Because actually, we used to, not relatively recent actually, for younger patients, consider doing 2 transplants. The idea is that you do transplant sort of soon after they're collecting their stem cells. And if this transplant worked particularly well, and by that I mean it kept the disease under control for a long period of time, you might try doing it again. But I think now, because the newer drugs are so good, that the role of a second transplant, it's just very rare now to do that, particularly in light of the age at which people might be going forward for transplants. And the reason that's important is when you're collecting stem cells, you just don't need to collect so many, because you only need to collect enough for 1 transplant rather than 2. There may be exceptions, but in the majority of cases, you're just collecting enough for 1. And I think generally the threshold is what we call 2 million cells. So the threshold used to be 3 million, but I think most people now go with 2.
There's a move to collect less stem cells. I think the other thing to say is when they're frozen, they last for years.
Yeah.
So if for whatever reason people have collected loads and you may still have some cells that are frozen, people are using these cells, 5, 6, 7, 8 years later, potentially. But as you say, there are less indications now, Sally, for doing many less indications for using them again. But when they're frozen, cells last. And if you're not sure whether they're viable or not, you can take a small amount of them and test them in certain ways to give you confidence that they're still going to be okay.
Yeah. Now, Jam, I want to ask you a question, because I think stem cells, it is out there, isn't it? The terminology of stem cells in some arenas, in particular in relation to other types of transplants and collecting stem cells from babies. And so we mustn't confuse the two. When a baby's born, you might collect the cord stem cells.
So these stem cells are autologous stem cells. We say autologous because they are from you. They're your own. So these are autologous stem cells. Now, in some diseases, allogeneic stem cells are used. Now, this term means that these are cells from other people, and they may be relatives or what we call unrelated donors. So healthy people that are on what we call donor registries may be called up to donate stem cells for certain types of other transplants in hematology for different conditions. And Sally, you mentioned the third type of stem cells, which are like cord stem cells, which are very specialized types of stem cells that are, again, used for certain types of other hematological disorders. But in myeloma, through decades of research and looking at different types of transplant, the only one that has stood the test of time is the autologous stem cell transplant. And that's why autologous stem cells are the only ones that are collected.
Yeah, absolutely. And the reason I mention that, not to confuse matters, but sometimes people think, you've got your stem cells, let's say they're stored, as you said, you can store them for many, many years, that they're like they're a backup, they're a safety net, and they're really precious. But it's really important to say in the context of myeloma, they have utility for a transplant. If you're not having a transplant, they don't have utility. They're not useful for that person, because often, let's say if someone has a transplant when they're 69 and they're in remission for 5 or 7 years afterwards, it's unlikely that you're going to want to have another transplant just because that person is a little bit older when the disease comes back. So we often now have to have conversations actually about destroying those stem cells. And I think sometimes that can come as a surprise to patients and their relatives. It's like, well, they're mine. Why? I want to keep them just in case you need them in the future. And so it's really important for us to share that they have this very particular indication, and beyond that, we don't know of them being of any benefit.
So, Sal, our patient's been on the machine for 4 hours, collected adequate stem cells, they have been frozen and stored, the cannulas have been taken out, and they go home, and it's all done as an outpatient, and generally people feel fine afterwards. People can feel a little bit odd if the calcium goes low, but that's generally pretty transient. And then usually there's a number of weeks in between the stem cell collection and the transplant, on average, maybe 4 to 6 or even 4 to 8 weeks. And people generally feel well during that time. So that's the process of stem cell mobilisation and collection.
So to have a bone marrow transplant for myeloma, we tend to use stem cells from within the patient's own body. And those stem cells enable us to give really good but really strong treatment to the patient. And we enable that person to recover from that treatment through using these stem cells. And this is where this part of the process is so important. We'll talk about the transplant a bit later, by the way, so watch out for that for everyone listening. But in a nutshell, we want to collect these stem cells. To enable us to collect them, we need to boost their production within the body with a series of injections normally, which you have for about 5 days, called GCSF. Following that, when the stem cells are nicely circulating with the blood, you attend hospital, you have a cannula put in your arm, and blood is taken from your body, the stem cells are collected and into a bag, and the blood is returned to the body, and at the end of the day, the stem cells are frozen down to be used later.
It sounds so simple and straightforward now, and for the vast majority of our patients, it is. But it is certainly the result of decades of amazing research, and it is extremely clever. But it is so fantastic for our patients that most of the time it is just as straightforward as you described.
Yeah, absolutely. This is part of the pathway, the treatment pathway, I think, which can feel like a big hurdle. It is a hurdle. You do need to overcome it, but it's pretty stress-free, I would say. You know, everyone needs to stick to the program, have their injections, let us know if they've got pain, and near enough everybody gets over the line, and then it's just waiting for the transplant.
Which is a perfect place to leave this, Sally, because we've done the induction chemotherapy. We have now mobilised and collected our stem cells. So over the next couple of weeks, we're going to be talking about autologous stem cell transplant in myeloma. I'm really excited for these next few podcasts, Sally. We're going to talk about the transplant, you and me. We're going to get one of our wonderful transplant nurses from Oxford to come and talk about how she counsels a patient for a stem cell transplant, how people are going to feel during the process. And then, of course, we're going to get more patient voices to give their own personal experience and journey on what their stem cell transplant was like.
Yeah, brilliant. Hopefully some really great content ahead, everybody. So reach out, let us know, and we really look forward to speaking to you again soon.
Thanks so much. Lovely to speak to you again, Sally, and we'll see you all at the next one.
Cheers, bye.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.